I'm Susanne Binder. I'm from Vienna, and from my background, I'm a vitreoretinal specialist. But as you perhaps know, in Austria, if you want to become a chair of a department, you have to present the knowledge of all kind of surgery. So I always did cataract surgery and glaucoma and some cornea. But on my scientific level, I'm a vitreoretinal person. And I have been with the Austrian-American Foundation for almost 20 years. And I've seen that this group has now become even more international. We have people not only from Eastern, but also from Western Mexico. Who is from Mexico here? Great. And we spend the next 3 hours together. So please, you can interrupt me and ask questions. It's supposed to be a very, informal way of presentation, and I really enjoy to share my knowledge with you. In general, this group has presenters of different levels. So some of you will be rather young in ophthalmology with not so much surgical experience. Some of you might be also vitreoretinal surgeons and might be bored from some of the things I tell you. So I try to merge everything together. The main thing is I want to be very clear, and we can have a lively discussion, as I said. My first topic is macular degeneration and cataract surgery. Who is doing cataract surgery? Yes. As macular degeneration is becoming, increasing in numbers, and cataract surgery is even more increasing, we sometimes are faced with the problem, what should we do with a patient who has both, actually, a cataract and also a macular degeneration. Both are age-related diseases with a common etiology, and there is an association between lens. Wo habe ich den Pointer? Lens opacification and AMD. And there are biochemical, biochemical signs of a common etiology. They both have low level of antioxidants, zeaxanthin and lutein. How is about the literature? And the literature in this kind of topic has changed over the past, let's say, 20 years. There were reports which said that in exudative AMD, this has a high tendency to progress after cataract surgery, and that was at the time when we did neither have PDT nor intravitreal injection. Many of you cannot remember this time, that we did not have treatment if AMD was progressing besides laser treatment, which was done sometimes. And there is already some literature which says how patients with early AMD, they benefit after cataract surgery in terms of visual function. And I think it's very important, because if the patient comes to the doctor, the eye doctor, then in earlier years there was a general rule that the eye doctor said, you have macular degeneration, you cannot have cataract surgery, you just have to wait. And there was not really a clear answer how long a patient should wait. Now, one of the big problems with all these big studies, and I will show you that through this lecture, is that it's usually difficult to grade the cataract and grade the AMD status. Here you see a fundus picture of a patient with a cataract and some drusen, but it's not very clear behind the cataract. You cannot really see. You think he has just 5 or 6 drusen and this is nothing. And on the other picture, you see that this is the patient a week after surgery, and he has actually multiple drusen because it's better visible when you remove the cataract. And this was very often already considered as a progression of the disease because there was more after that than before. Now, how can we overcome this issue? Now, actually, all these old studies would have needed new imaging systems. And here you see that was from Dr. Holm in Sweden. He recommended a certain lens system which enhanced the fundus pictures and would actually give you a much better information of the preoperative status of the macula than we usually had with fundus photographs. Now, what were other grading pitfalls? A clinically dry AMD is actually already exudative, and we don't know, or we did not know. And here you see a picture of a patient with a cataract. You don't see very much. There are some drusen, dry, of course. And if you would have done a fluorescein angiography, you would have already seen that the patient has a neovascularization, so that this case is already wet before surgery. And then, of course, if you do cataract surgery, yes, these cases, they will progress if they are not treated. So, yes or no? There is a lot of arguments which say the course of the macular degeneration is not influenced by cataract surgery, but this is rather the old literature. And they all have different study designs, and they all used only fundus photographs for their evaluation, which are clearly not enough anymore. And there are other studies which say cataract surgery may influence pre-existing AMD because there is a sign of common etiology. I talked about that. There is higher postoperative light transmission through the implanted lens. There is the question always of surgical trauma. How much does the light of the microscope, the circulation of inflammatory mediators, the change of the vitreous and intraocular pressure influence the progression? And there are 2 actually large clinical studies which showed that late stages of AMD have a higher tendency to progress after cataract surgery. So it's not very clear, and I try to shed some light into that. We did many years ago an prospective comparative study on this issue, and we included patients with cataract and dry AMD, which had drusen with or without pigment epithelium atrophy, but late stages were included. And what we did is one patient had cataract surgery in one eye, and in the other eye, the cataract surgery was delayed for 6 months. Why 6 months? Because you could not ethically delay the cataract surgery longer. Let's say it would have been better that we would have waited a year, but this was not possible with the ethics committee. In this study, we used a grading system for the cataract. I think you know the log system, where you standardize it into color, opacity, cortical, posterior, subcapsular. And we used a minimum grade of 2.1 in one category. And we had a colleague in Aberdeen, and she helped us with the quantitation of the drusen. She has a special filter system so that we could really evaluate the drusen area before cataract surgery. The results at that time, there was no change was seen in AMD size and classification in both groups, and no case of the study population an exudative AMD had developed after a year. So they remained stable when they had dry cataracts. However, 5 of 52, so 10% of clinical dry AMD were exudative in fluorescein angiography and OCT preoperatively, because study eyes are always much better examined. So in these cases, we did angiography and OCT, and we could filter out these few cases which were already exudative before surgery. At that time, I think they had PDT treatment before, and cataract surgery was done later in these cases. So, what is the perspective? Fluorescein angiography in high-risk AMD before ophthalmic surgery should be considered if you are not clear about the case. In the normal clinic routine, it's rarely done. You probably today, fortunately, we have OCT, and it's safe and non-invasive, and you are much better off to do an OCT in these cases, and only if the OCT is not very clear, you might consider fluorescein angiography. Whether the surgery itself might lead to progression, we think we could show that in 12 months postoperative follow-up, this was not really an issue, because this was modern cataract surgery. We have smaller incisions, we have shorter surgical time, there is not so much fluid exchange, so the way we do cataract surgery is lesser traumatic also. So still, the long-term course, and we will discuss this during this hour, needs to be evaluated, but because it's not really very clear. So there is a literature which is now a little bit more recent, which says there is a higher risk of AMD progression after cataract surgery. This is a study after subfoveal PDT, 1 to 1.5 years after the surgery, and they found a 2.7 times higher risk for wet AMD, but preoperatively, there was not very much done in these cases. There was another study which said that there is an increased risk of late AMD in pseudophakic patients 5 to 15 years after cataract surgery. And this is really a very big study from Wang and Mitchell in Australia. And they found that in non-phakic eyes, there was an incidence of a late AMD of 6 to 7%, 5 to 15 years, versus only 0.7 in phakic eyes. So they found a 10 times higher risk in these elderly patients. And there is also another study where they found after 10 years 3 times higher risk for AMD. And at this point, what is your impression? Do you sometimes see patients many years after cataract surgery where you feel they, or that you have a more progression, or do you have an opinion on that?
They usually don't come again.
Hmm?
They usually don't come again.
Well, this is probably the best answer, because we cannot solve this problem because many of these patients we don't see anymore. So this is a selected group. If they can catch them 10 years later, yeah, but in general, there are not these long studies where patients would really, if they have surgery with 75, not so many will come again with 85 or 90, and therefore we don't know. I personally have the feeling that pseudophakia plays some role in the development of AMD, but we will also not have very many 85-year-old patients which did not have cataract surgery in our level of medicine. So we need to find this out, but it's not an easy thing. Okay? So let's continue. There is, as I wanted to say, there is another study group, and which says for dry AMD there is no risk of progression. This was also a year after cataract surgery, but now in the 2009 they were a little bit more clever with their studies, because they already excluded patients who had wet AMD before cataract surgery. So this, we have learned something. And this is from Emily Chu, who is doing all these ARET studies. I don't know if you know her name. Yeah. And they did then a retrospective review and found out there is no higher risk of prevalence and progression in pseudophakic eyes. So, and also Dr. Sutter. In general, it was now in the 2010 years, it was now then accepted that there is a greater benefit after cataract surgery if they have dry AMD. Don't let them wait endlessly with your cataract surgery, but because they really profit after cataract surgery. I, in general, wait a little bit if they have problems with their reading vision, if they have cataract intrusion. If they can still read the newspaper, I don't see a reason to do cataract surgery too early. So I will not be too quick. They have to have a kind of substantial cataract. On the other side, I don't delay them endlessly so that they are really helpless. Because I think if they have an OCT, if I know what's going on, they can have cataract surgery and they will profit. So if the removal of the cataract does support the progression is still unclear. But from a recent study in 2020, we know that there is more progression in Asians than in Europeans and Americans, and this is even more unclear. So, from the first part, patients with early dry AMD and substantial cataract profit from timely cataract surgery at least in the first 1 to 5 years. And many of these patients, as sad as it is, they don't survive a longer time span after cataract surgery. OCT, I think, is mandatory. If you see some macular changes before cataract surgery. But the percentage of patients with late AMD is higher. So we have discussed this. What could you do with these patients? How do you communicate with these patients? What you have to do is that you have to tell the patient after cataract surgery there might be still not an excellent reading vision. Because many of these patients, they will believe that now when the cataract is removed, my neighbor had cataract surgery, she can see so well, so she expects from you that her vision will also be perfect. And if you undertake cataract surgery and you don't warn the patient that his macula has some involvement and his reading vision might become better but will not be great, or it's unclear, then you are much better off. Otherwise, the patient will complain all the time. So you need to discuss this. These patients need much more time from your time than other cataract patients. You need to discuss the surgery. Even though it's done perfectly, you might not see as well as you would like. Then if you have an example, there are two eyes. One has little AMD, the other more advanced AMD. Which eye would you do first? Yes. Because the patient will be happier if you do the patient which has only little cataract, and then he will want the other eye, but he's already warned. How many are doing a lot of simultaneous cataract surgery? No. So I have to admit, in Austria, there's a lot simultaneous cataract surgery done, both eyes all the time. I would not recommend that for patients with AMD, because it's always wise to figure out how the patient responds to the first eye, if he's happy with that. And if you do the surgery on both eyes, you might get into some troubles. So simultaneous surgery is actually, for me, a no-no in cataract surgery, in AMD. So how about the surgical technique? Do you feel that these patients, you have to approach differently with your cataract surgery?
Maybe the cases with wet AMD that have the scars, their retina is a little bit thicker, they tend to get hyperopic. So just for the IL calculation.
Yes, and they are very often hypermetropic also before cataract surgery. That's connected with AMD, but these are not beginner eyes in general. Even if you think it's an old patient and this can do my young colleague, it's not a beginner eye. They very often have shallow anterior chambers and pressure from the back during surgery, especially in exudative cases. And I would recommend that you prepare them a little bit different. I give them a Diamox before surgery, and I move very slowly in surgery. In earlier years, I don't know if you have ever seen that, we did perform oculopression on the eyes when we did intracapsular cataract surgery a lot. This was a kind of some pressure. It was fixed around the head. It's done in Africa still. They put a stone on the eye for 10 minutes. And then the vitreous is compressed with this soft oculopressor, and the eye gets very soft so that there is no chance or little chance of vitreous prolapse. And so we don't, this is an old instrument, it's not used anymore, but you should lower the pressure. which lenses do you choose? Would you recommend a yellow lens? There are a lot of yes. Can I have a raise of?
Because of the UV light, they have the.
There is a no. Why?
I was in a paper with Dr. Marty Mainster, who I think you know, and he did like a big review of this, and it's just marketing. So supposedly if you use jello blocking lenses, you just look the blue light, but actually that causes trouble to patients with AMD because they get lower contrast, and the thing they say it's protecting against UV light, it's not.
So there are different philosophies. Let's put it in this way. Because I had a phase, I have to say, it was probably 10 years ago, when I switched from white lenses to yellow lenses for patients who had some macular involvement. Yeah, and were elderly patients. Most of them did not drive. Now you have for the 80 years they want to go on the road. But so the driving and the disturbance of was not the greatest issue, and we felt that we might protect the macula because we excluded the blue light filter. Actually, it was shown that this was not really the case, and it's up to you what you would like to do. I discuss it with the patient, and I tell the patient that if I implant the yellow lens, because there are a lot of patients who will say, which kind of filter, and does your lens have all the filters I need that my macula is not further damaged? Patients are not, they go on the internet all the time, they know a lot. And then I usually tell them that if I implant the yellow lens, and I'm willing to do that, then they might have some troubles in driving or in, and but they might have lesser light sensitivity in general. Many old patients, they complain that now the light is so bright and it's irritating, they have to wear sunglasses all the time. And then I actually let them choose. Because they have reduced contrast sensitivity and driving might be difficult. Multifocal lenses. Who is implanting multifocal lenses a lot? We have a colleague from Mexico who is doing everything. You are doing everything, yes?
A little bit of everything.
Yes.
But I'm really doubtful about multifocals in this kind of patients. What's been your experience?
I will not implant a multifocal lens in a patient who has some drusen. I see a lot of patients who had Switzerland is fond of multifocal intraocular lenses. So they come from Switzerland and they have some progression. And I think then they suffer even more with a multifocal lens than if they would have a monofocal lens. So there are some studies in the literature which actually would support your idea that you can implant a multifocal lens even in a patient with AMD. I would never do it, to be honest. I'm not a big favor of doing it too much. I really talk a lot with the patient's expectations in multifocals, but if they have some AMD or some drusen, I would not recommend it.
I'm worried about the people in, I don't know, in Austria, but in Mexico, they're starting to get cataract surgery early, like in their 50s, so that in a few years we're going to start seeing patients that develop AMD with multifocal lenses, so it's going to be...
I think it will be very tough. They will also have some capsular fibrosis a little bit earlier, which is more difficult to yak behind a multifocal lens. And also our judgment might be a little bit less if you have a multifocal lens. Yeah. So, we agree on that. So then you have given 20 Avastin or Eylea injections already in a patient's eye. And this patient, and you tell the patient, you know, when the retina is dry, then we will do your cataract surgery because then you have a lower risk of everything. Now, this retina does not get dry. You have some patients which have some chronic residual fluid. And now there are newer studies which actually say this is not the worst thing. If they have a little bit of fluid, it might support the photoreceptors a little bit more than if they are totally dry. But this was our rule. The retina has to be dry to do cataract surgery. And so fortunately we have anti-VEGF treatment, and then there is the discussion, how do you put this patient in your line of management? That do you do anti-VEGF treatment 2 weeks before, which would be in the middle of 2 injections, and do cataract surgery in between? Or do you see, would you prefer to do the anti-VEGF treatment simultaneously with cataract surgery? In between? In between? There's nobody who is doing it simultaneously. Courageous person too. So I'm doing it simultaneously, to be honest. And I tell you why. Yes, we have anti-VEGF treatment, but very often these patients after cataract surgery, especially if the cataract surgeon is not the medical retina person, then they are lost for a certain time. And then they progress after cataract surgery, and they come to the medical retina person a little bit too late, where exudation is already much more severe. So we know by spectrometry that we have circulating inflammatory cells probably 5 to 6 weeks after cataract surgery. So the postoperative treatment, what we do is in general 2 or 3 weeks after anti-inflammatory drops and cortisone, or what is your usually routine? I use Yes, how long?
Like for 4 weeks.
Mm-hmm. Longer? Somebody longer? Yeah. So I usually treat a cataract patient 3 weeks with a combination of anti-inflammatory and corticosteroids. AMD patients I treat longer, 5 weeks sometimes or so, just to get rid of that. But we have not finalized the question of simultaneous or in between. And I did a pilot study, and it was at the time when anti-VEGF came up on the market, and we were all, we didn't know too much. And in this study, we said that a combination of both could reduce the likelihood of postoperative visual deterioration due to the increase of central fluid or neovascularization. And we used Lucentis at that time or Avastin. And I did simultaneous cataract surgery, and at the end I just injected the anti-VEGF in these patients. We wanted to know, does it delay wound healing? Is there a problem with intravitreal bleeding, or is it well tolerated? And I can tell you, and here you see a patient, it had some confluent drusen, so visual acuity he had Avastin in cataract surgery, and usually the vision comes back. It takes a little bit longer after 2 more Avastin injections. His vision was 0.3 compared to 0.15. So this was a good case. What we also learned that the anti-VEGF is well tolerated, even if you use it at the same time. We had no wound healing problems, no endophthalmitis or IOL dislocation or retinal detachment. There was a transient pressure rise in 3 of these cases, no rapid loss of vision, and an improvement of visual acuity after 1 and 3 months. So it's up to you. I know you can do it 2 weeks before cataract surgery to prepare the patient somehow, but you could also do it at the same time. You just reconsider. Because then I see the patient post-operatively, of course, and then I see him 4 weeks later. And at that time, and I feel my anti-VEGF injection during surgery has kept this eye quiet for these 4 weeks. Yeah. So, and there is already also literature with cataract surgery and anti-VEGF. And it says that the mean gain was 2 lines, and cataract surgery is safe in treating exudative AMD patients too, because you will have them. And there is a 3-line improvement in this other study, no adverse events, and there is also an improvement in vision and no perioperative complications or in adverse events. So now we can do cataract surgery also in patients with exudative AMD, but they need some treatment first or at least at the same time. Most of these cases are already in your program. They had already a lot of AMD patients, but sooner or later you have to decide now to do the cataract surgery. So as a conclusion, patients with early dry AMD profit from timely cataract surgery because 10% of your early dry cases might be already wet. OCT is mandatory preoperatively in these cases, or you have to add anti-VEGF. Anti-VEGF simultaneously is well tolerated, does not increase the risk of surgery. There is no delay necessary. However, we still live with the evidence that 10 to 15 years after cataract surgery, more pseudophakic eyes will have late AMD than the phakic. Overall, and this is probably the most important, careful and more frequent follow-up is necessary in these patients, including OCT and further anti-VEGF therapies if necessary. So you cannot lose these patients, and you have to take better care than what you might usually do with a normal cataract patient. This is an issue which is actually now evolving also in other areas. This is not my topic, but we see an increase in retinal detachments worldwide. And we have done a global study, and there are actually 2 reasons why retinal detachments increase. One is myopia, and is increasing, and therefore in the younger age group, retinal detachments to increase. The second one is cataract surgery, which is done now much earlier or sometimes for refractive reasons. And therefore we have in the elderly group also an increase in cataract surgery. But it's also that I feel that we do not take so much time anymore to look post-operatively in cataract patients in dilate the fundus and look at the retina unless the patient complains about some symptoms. The patient is happy, we are happy to look and let him go. In earlier years, we dilated every time the fundus and checked the retina. Nobody is actually doing. We don't want to do that. It's also that if the patient comes in with some vitreous complaints, some light flashes, and you examine the patient now finally dilated with the 3-mirror glass, there might be some capsular opacifications where it's very difficult to see a very small tear. So we actually wait until the patient has a clear retinal detachment, and this is also a factor. But it's not my topic. This was my topic, and I'm ready to take some questions. And thank you very much for your attention.